This study examined how individuals affected by anorexia nervosa process interoceptive body signals before and after eating a meal. To understand what prompted us to conduct this research, it's important to know that interoception refers to the processes involved in sensing, integrating, and acting upon signals that come from inside of the body. Ever since the term anorexia nervosa was defined, clinical descriptions of AN have portrayed individuals who are apprehensive, not just about eating food, but about the state of their bodies. And while they were preoccupied with abnormal perceptions of their body exterior, as in the fear of becoming fat that we recognize as part of the diagnostic criteria under DSM-5, they also frequently worried about abnormal experiences happening inside of the body. Some of the earliest and now classic case reports even emphasized that vague feelings of fullness or a failure of recognizing bodily states were key illness characteristics. These observations and others have contributed to modern theoretical accounts asserting that interoception is abnormal in AN. Now, although the clinical recognition of interoceptive dysfunction in AN has been long-standing, it's actually been understudied by the scientific community. The first study of interoception in AN suggested that interoception was impaired. 3 individuals with AN failed to detect small volumes of a liquid milkshake that was delivered directly into the stomach. Now, this approach was invasive and it was uncomfortable for participants as it involved the delivery of food directly into the stomach via a tube that they had to swallow. More recently, several non-invasive studies have looked at awareness of heartbeat sensations in individuals with AN and also bulimia nervosa. These studies have produced mixed results. In some cases, differences were found between patients and comparisons, and in other cases, no differences were found. These inconsistent findings could be explained by the use of several different methods for measuring the heartbeat sensation. However, we believe that a bigger limitation is that all of these studies failed to measure interoception across the range of conditions relevant to AN. That is, during changes in the levels of bodily arousal and emotional state that can occur around meal times. For example, how differently would you feel your heartbeat sensation while sitting on a couch versus after sprinting 100 meters, or riding a roller coaster, or right before giving a public speech? We believe that the lack of focus on this sort of dynamic measure of body perception could explain the inconsistent findings in these earlier studies. To address this issue directly, we designed our studies so that we could produce body arousal responses in the cardiac and respiratory systems by using infusions of a medication called isoproterenol. Isoproterenol is a medication similar to adrenaline. It was originally developed as a treatment for asthma attacks because it works by relaxing the airways. However, it also stimulates the heart, and as a result, asthma patients reported prominent heartbeat sensations. This resulted in the development of other medications, newer medications like albuterol, which preferentially relax the airways without stimulating the heart as much. Although isoproterenol is no longer used to treat asthma attacks, it has become a useful tool for measuring interoception because when infused intravenously, it results in rapid but brief changes in the intensity of heartbeat and breathing sensations. Some advantages of this method include the fact that the effects are quick to disappear and that it is less invasive than swallowing a tube. As a result, isoproterenol has been used in human subjects research for more than 40 years now, including in studies of AN. The purpose of our study was to evaluate whether individuals with current or lifetime AN show evidence of impaired cardiorespiratory interoception right before and immediately after eating a relatively large meal. We went about trying to answer our questions by using infusions of different doses of isoproterenol and saline applied before and after completely consuming a 1,000-calorie meal. This meal included an appetizer, main course, beverage, and dessert, and participants were informed they were required to consume the entire meal. To accommodate different dietary preferences, participants selected from 3 different meal options, vegan, vegetarian, or non-vegetarian, all with the same calorie content. We chose this meal intervention in order to evoke and study individuals during the experience of food-related emotional arousal that's a defining characteristic of AN. During the experiment, participants rated the experience of internal body sensations, both during and immediately after receiving infusions of isoproterenol or saline. During each infusion, they rated their moment-to-moment experience of the intensity of their heartbeat and breathing sensations by rotating a dial. And after each infusion, they reported separately the intensity of the heartbeat and breathing sensations that they had felt. Participants received a range of doses during the pre-meal and post-meal sets of infusions. Importantly, these doses were administered in a double-blind fashion, meaning that neither they nor the experimenter knew what to expect from each infusion. This allowed us to effectively measure the degree to which each individual perceived increases in their internal body sensations. We studied 15 women with a history of current or prior AN. The average age was 23 years. To ensure that they were not in the acute starvation state, all participants with AN were required to have a minimum body mass index, or BMI, of 17 or greater on the testing day. This was to ensure that any differences in subjective ratings would not be influenced by fatigue from starvation or structural changes that have been known to occur in the brain. We studied 15 unaffected women around the same age to serve as healthy comparisons. We found that both groups showed similar physiological responses to the drug. However, we found that overall, the AN group was significantly more likely to report increases in their heartbeat and breathing sensations, 4 times more likely in fact. This was true not only across the pre- and post-meal conditions, but it was also true at low arousal levels, in other words, at low doses of isoproterenol. In fact, the AN group was significantly more likely to report increased sensations during the saline infusions when we did not induce or observe any physiological changes. One of the notable findings was that these differences were most pronounced during the pre-meal condition immediately prior to when participants were expecting to eat the meal. This difference seemed to be driven more by reports of increased dyspnea, or changes in breathing sensation, than by reports of increased heartbeat sensation. When we looked at the ability to track bodily sensations in real time, we found that both groups were less accurate at tracking bodily changes after eating. This meal-associated decrease was more pronounced in the AN group, although we should note that when we looked at both groups, they were both fairly accurate at rating their body sensations as the dose increased, and they did not significantly differ overall. We think that this all means that individuals with AN tend to have difficulty detecting and separating actual interoceptive sensations from anticipated ones, particularly at low levels of bodily arousal, when the body may not provide sufficient cues as to the state of the external or internal environment. We think that this mismatch between expected versus actual outcomes produces an interoceptive prediction error. We believe that these interoceptive prediction errors can cause or increase abnormal feeding behaviors. For example, we believe that for individuals with AN, looking at food, smelling food, or eating food can generate an aversion that is in conflict with the inherent reward associated with consuming something that's necessary for survival. This mismatch between anticipated and experienced states induces a negative emotional state, which can increase urges and behaviors to avoid food. As a result, these interoceptive prediction errors can encourage or reinforce many of the abnormal restrictive feeding behaviors that are observed in eating disorders like AN. We believe that understanding the neurobiological basis of these interoceptive prediction errors will help us to better understand the pathophysiology or expression of eating disorders, and therefore has the potential to illuminate new approaches to treatment. The biggest strength of this study is the use of a robust measure of interoception via pharmacological modulation of the internal environment, combined with a robust measure of feeding state via modulation of meal consumption. Each of these approaches represent interventions with well-defined peripheral and central neurobiological targets that are highly relevant to the expression of AN. In other words, we would argue that these features of our study indicate a high level of ecological validity or high ability to generalize these findings to real-life settings. It's important to understand that there are several limitations to this study. First of all, we studied a small sample of individuals with AN. This limits our ability to confidently generalize these findings to the entire population of individuals affected by AN. Secondly, while AN was the primary clinical diagnosis of individuals in our study, we allowed individuals into the study who also had comorbid diagnoses. Although this potentially weakens the ability to ascribe the findings directly to AN, we believe that the diversity of this sample is more reflective of the variety of disorders that clinicians in the community typically encounter and treat in their ED patients. Thirdly, along the same lines, we did not exclude individuals who were treated with certain medications, such as those with serotonergic activity. And in fact, in our study, less than 30% of our sample was medicated. We felt that this was acceptable given that these types of medications have shown limited efficacy in reducing the symptoms of AN. Although we now know that individuals with AN experience cardiorespiratory sensations abnormally while anticipating eating a larger meal, we believe that it is important to identify the degree to which changes in breathing sensitivity are responsible, as well as identifying which brain regions are drivers of this exaggerated anticipatory state. We also need to understand the role of emotion in this process, especially since many individuals with AN find meal anticipation to be anxiety-provoking even in recovery. Future research should therefore attend to the role of negative affective states, such as anxiety and panic surrounding meal consumption. Neuroimaging studies of AN will also be important for clarifying the neurobiology associated with these states. We believe that a specific focus on neurocircuitry related to anxiety, fear learning and fear inhibition, and emotion regulation would help to identify neural targets that in the long run might provide a focus for intervention as well as measures of treatment success. Unfortunately, the areas of interoception research and eating disorder research are understudied. First of all, clinicians and researchers may consider attending my talk at the upcoming International Conference on Eating Disorders in San Francisco in May. I will be presenting a follow-up to this study focusing specifically on the roles played by negative emotional states, such as anxiety and panic, in our findings, and will also be presenting further evidence of abnormal bodily representation in AN. For people interested in the topic of interoceptive prediction errors in anorexia nervosa, there are currently no generally available books. However, I would highly recommend a scientific review article published in Nature Reviews Neuroscience in 2009 by Walter Kay, Julie Fudge, and Martin Paulus titled New Insights into Symptoms and Neurocircuit Function of Anorexia Nervosa. There are a number of other good scientific review articles and books that I could also recommend. Feel free to contact me by email at skhalsa@laureateinstitute.org. Looking back, the biggest challenge that we faced was the amount of coordination and resources required to execute this study. This study was conducted at UCLA, where we were fortunate to have the benefit of nursing, pharmacy, dietitian, and statistician collaborators at the UCLA Clinical and Translational Science Institute, as well as cardiologist support through the UCLA Cardiac Arrhythmia Center. We also had staff support from members of Dr. Fusner's lab, including Courtney Sheen and Larissa Portnoff, and guidance from our senior co-authors, Drs. Michelle Krask, Michael Strober, Wei Li, and Jamie Fusner. Finally, we were also fortunate to receive generous participant referrals from several community treatment centers, such as the Eating Disorder Centers of California, the Center for Discovery, and the UCLA Eating Disorders Program. I would say that the most rewarding part of having conducted this study was participating in a concerted, multidisciplinary team effort focused on developing a new understanding of anorexia nervosa, which is one of the deadliest, most elusive, and unfortunately, most understudied disorders in all of psychiatry.